So I think we'll continue now with a lecture from Dr. Justin Richardson. He is one of the neonatal staff working with Elon now in the NICU, just recovered from COVID.
Recovering.
Recovering. I'm happy that you are alive.
I may still cough a lot. I may still cough a lot.
But we are happy that you are improving and that you could join the meeting and speak to us. So the point is that in this lecture, we want to emphasize a little bit the approach to the preterm babies and see what we can and have to do in order to prevent complications. So Justin, Yarona is, you appear as Yarona.
Okay, it's my wife's name. Yeah, yes. I'm on her laptop now. And share screen. Aki, I just wanted to ask you, it's already 5:25. How long? Are we a long way behind schedule already today or not? Okay, I will start, and then if we're looking like, because Aki, your microphone is muted, so I will start, and if we look like we're getting too far behind time, break it in and we can try to make it shorter.
No, don't rush. You make your talk, and maximum will move one of my talks to another meeting. It's fine.
Okay.
We want to encourage discussion, and that's how it is.
Okay.
We started a little bit late, so it's okay.
Okay, thank you very much. As Dr. Aggie said, my name is Justin Richardson. I'm a neonatologist. I'm originally from the United Kingdom, but I've worked for many years now at Soroka with Dr. Aggie and with Professor Elon. Forgive me if some things that I say are not relevant. I have never visited your units, but I'm very happy to be part of this program. The questions for this talk are: what complications of prematurity are our infants born preterm at risk of? When are they likely to occur? How can we detect them, diagnose them? We'll only mention very briefly.
Can you go to the presentation format, please?
I can try. Is that better? We spent a very short time looking at the treatment and the complications and outcomes because it's because of time, but we will look at considering what recognized prevention strategies that there are that may be relevant to us all. We're going to start with at the top with the brain with intraventricular hemorrhage. Intraventricular hemorrhage is bleeding into the ventricular system. And the ventricular system is a series of chambers within the brain that are connected to each other. CSF, the cerebral spinal fluid, is produced from the choroid plexus, which is a structure contained in the chambers. And this fluid then circulates through them and out onto the surface of the brain and the spinal cord. Babies born before 32 weeks gestation are at risk of IVH, and the origin or the site of the bleed is from a structure called the germinal matrix. Here we're looking at the brain from the side.
We cannot see your slides moving, Justin.
They haven't moved yet.
Ah.
Second.
Sorry.
Good reason.
Here we're looking at the brain from the side, known as the sagittal view. And now on the next slide, we're looking at a cut surface through the brain.
Justin, Aggie is right. You're not showing the presentation.
What am I showing?
You have to share the presentation itself.
Hang on.
Stop the sharing and reshare the presentation itself.
Okay.
Okay, when you do the share screen,
Yeah.
either share your screen or the presentation. It's better to share the whole screen.
Hang on.
You get me?
I'm trying. Is that now?
I don't know. Try to click on the presentation mode. No, where your pointer was right now. No, you stopped the presentation.
Okay.
Go to share screen, and then you have the option of screen. At the left side of the screen, you have screen. Then you
Okay,
share the screen, then you go to the presentation, and you do with it whatever you want. We will see it.
Okay, share screen, and now what do I do?
Push. You have screen there. You're able to share the screen itself.
Okay.
Great. Now go to the presentation and push the presentation mode.
Okay. Is it
great? Here you
is
go.
it okay now?
Yeah, it's fine.
Okay.
Excellent.
Hang on. Okay.
Don't show us these pictures, please.
Why?
Why?
Okay. So here we can see the ventricles, and we can see this structure called the germinal matrix. And the germinal matrix is next to the lower inner wall of the lateral ventricle. What is the germinal matrix and what is its function? The germinal matrix is a loose collection of very immature cells that germinate or differentiate into the neurons of the brain. So in fetal life, the neurons develop here within the germinal matrix. And from here, they migrate outwards into the basal ganglia and the cortices. The germinal matrix is metabolically highly active and needs a large blood supply, which is supplied by a fragile network of capillaries throughout the lattice-like structure. Changes in the hemodynamics that occur after birth place the preterm infant at risk of bleeding into this fragile vascular structure. Infants born after 32 weeks gestation are at much lower risk of bleeding from these sites, as its function in neurogenesis is largely complete and the germinal matrix itself has started to regress. By the time the baby is born at term, this structure ceases to exist as a discrete structure. When does IVH occur? Well, changes in hemodynamics that occur at birth and during the transition and early days are what exposes a preterm infant to the risk of bleeding into the germinal matrix. And so this complication occurs early in life, most often within the first 3 days and almost always within the first week. How can I know if our infant has had an intraventricular hemorrhage? Well, the vast majority of them are asymptomatic. We don't see it. Of those who have symptoms, these are more likely to be subtle. Changes in the general condition, in the respiratory status, maybe in the level of consciousness, or we see a hematocrit that's falling. Only a small number present with collapse, but a massive bleed can result in hypotension, acidosis, respiratory deterioration, seizures, or a massive drop in hemoglobin or hematocrit. So because in many cases we don't detect IVH clinically, a cerebral ultrasound scan is the definitive method to establish the diagnosis and the grade of the bleed. An ultrasound is recommended in all infants born before 32 weeks gestation at between 7 and 10 days of life. Because by this time, virtually all IVH has occurred and reached its maximum extent. We want to know if this complication has occurred because if there is a high grade IVH, it's necessary to follow closely for signs and symptoms of post-hemorrhagic hydrocephalus. Also, the parents need to know the infant is at a higher risk of neurodevelopmental impairments and that follow-up will be needed in the future. The size of the bleed is graded using a system developed by Dr. Papil. And a grade 1 bleed is a very small bleed only into the germinal matrix itself and not into the ventricular system. Grade 2, the blood has spilled from the germinal matrix through the ependymal layer, which separates the matrix from the ventricle. And so there is now blood in the ventricle system. Grade 3 is where there is blood in the ventricular system with a distended ventricle. And grade 4 is where there's an intraventricular hemorrhage with an associated infarct, venous infarct of brain tissue. High grade 3 and 4 IVHs are associated with poorer outcomes, neurodevelopmental outcomes. And because of this, preventing IVH is a massive area of quality improvement in NICUs throughout the world. I'm now going to list some of the interventions that are in current use, and they're often put together in so-called bundles where several interventions are used together. Here are some of them. Antenatal corticosteroids, 2 doses of betamethasone by intramuscular injection, given 24 hours apart to the mother prior to preterm birth, can reduce the risk of high-grade IVH by as much as 50%. Dexamethasone can also be used in place of betamethasone, and these are cheap drugs with big effects on outcome. At Soroka, we are able to give the full 2 doses only about 60% of the time to mothers before delivery. And this is a challenge everywhere, especially if babies are born outside centres or if mothers arrive just prior to delivery. Discussions and liaison with obstetricians is needed to make this intervention a priority. Second, delayed cord clamping. The practice of clamping the cord at least 60 seconds after delivery in an infant who is not bradycardic has been shown to reduce mortality in infants after preterm birth, improves the hemodynamic stability in the first 24 hours of life, and there is a reduced requirement for packed cell transfusions during the admission. Whether it reduces the incidence of IVH is less clear, although it has in some studies, but it has been widely introduced as part of IVH prevention strategies. There are several occasions, however, when it should not be used, and these include where it compromises the care of the mother, whose condition takes priority. If there is hemorrhage, maternal hemorrhage, or severe maternal anemia, it should not be done. It should not delay the resuscitation of a bradycardic infant. And if there is a disruption of the placental unit, such as in an abruption or a bleeding placenta previa, it shouldn't be done. Third, it's recommended to avoid rapid boluses of drugs or volume in the first 3 days of life, and this also includes not performing umbilical cord milking at birth. Maintaining the baby's temperature from birth is important, as hypothermia will increase the risk of IVH. Minimal handling and reducing stress, I won't go into it now. We'll move on to the GI tract, gastrointestinal tract. Necrotizing enterocolitis, NEC. It's the most serious gastrointestinal complication and affects between 5 to 10% of infants born less than 32 weeks or 1.5 kilograms. Prematurity is the most important risk factor, but it can occur in older infants with other risk factors such as perinatal asphyxia or severe congenital heart disease. In preterm infants, NEC may be seen in the first week of life, but it is more usual to occur in weeks 2 and 3. What is it? It is an inflammatory and necrotic process of the mucosa of the small or large bowel. And what causes it? This is a complex question. There is no single cause. I find it best to use the triad model of inputs that interact differently in each infant, but the final result is cytokine-mediated inflammation causing mucosal injury. Factors in the triad. Feeds. NEC doesn't usually occur in infants who have never been given enteral feeds. Also, it is known that breast milk is protective compared to formula feeds, but whether this is related to the increased feed intolerance, increased transit time, bacterial overgrowth that can occur with formula feeds compared to breast milk, or if there is a specific harmful inflammatory element of partially digested formula milk on the immature mucosa is not known. Bacteria, pathogenic gut flora such as cons, E. coli, Klebsiella, and bacterial overgrowth are known to be important in the pathogenesis of NEC. Up to 1/3 of infants with NEC will have positive blood cultures, and the clinical picture of severe NEC is often one of sepsis with DIC. Ischemia. Infants who suffer hypoxic or ischemic events are increased risk of NEC due to intestinal ischemia from antenatal events sometimes, hypotension after delivery, or even a hemodynamically significant patent ductus arteriosus. In all cases, the mucosal injury can lead to bacterial invasion of the intestinal wall of the small or large intestine, and from there the condition can stabilize or deteriorate, leading to necrosis, cell death, and intestinal perforation. The diagnosis is made using the modified Bell's criteria. Stage 1 is suspected NEC. Here we have an infant with some abdominal symptoms and signs such as not tolerating feeds, maybe aspirates or vomiting. There's some abdominal distension plus blood in the stool. An abdominal X-ray at this stage this is a normal, on the left here is a normal, nice polygonal gas shape that we want to see in the X-ray of an abdomen. Here on the left, we see something called thumbprinting, which represents bowel wall thickening from edema, and is often what the kind of picture we will see in stage 1 necrotizing enterocolitis. Stage 2 is confirmed or definite NEC. Infants here will show the stage 1 features, but in addition will have abdominal tenderness, and the X-ray will show a diagnostic feature, intestinal pneumatosis, intramural gas, which is hydrogen gas released by bacteria that have invaded the intestinal wall. Here we see a line of gas here clearly in the intestinal wall. This is hydrogen gas from bacterial invasion. This is confirmed NEC stage 2, and the infant will either be mildly or moderately unwell at this time. The treatment for stages 1 and 2 are a variable number of days of bowel rest and antibiotic treatment. Please remember that if you have a baby with an acute abdomen and there is no signs of pneumatosis on the X-ray, that there obviously is a differential diagnosis, and have to consider all the other possible options. Stage 3 NEC is what we mainly call surgical NEC. It usually occurs once there is perforation. This will require surgical intervention, full intensive care, and mortality is high in these cases. Prevention strategies have been discussed a lot in the literature in ways to try to reduce the incidence of NEC, including feeding protocols, breast milk, use of breast milk, probiotics, supplements such as lactoferrin. I've chosen a few points today. Antenatal corticosteroids, once again, we see the benefit of this intervention. It's not as dramatic as for IVH, but meta-analysis show that composite outcomes of death or NEC stage 2 and 3 are reduced significantly by the use of antenatal corticosteroids. Exclusive breast milk feeding. I know I don't need to convince anyone in the seminar today about the benefits and importance of human milk in all infants for many reasons, but one of them is NEC prevention. Breast milk contains, in addition to nutrients, growth factors, prebiotics, immunoglobulins, and biologically active molecules that reduce necrotizing enterocolitis. Thirdly, we should avoid the unnecessary use of antibiotics, which can change the gut flora, and also things like H2 blockers or proton pump inhibitors. Probiotics is extensively written about in the literature and is used in many places. However, it is not a therapy that is available in Israel, and we have no experience of its use. I would say that all the benefits should be achievable with the use of exclusive breast milk. Moving on, this time back up to the eye, the retinopathy of prematurity, ROP. ROP is a vascular disease of the retina, so that it means it's a disease of the blood vessels at the back of the eye. Babies at risk of developing ROP are born before 32 weeks gestation or 1.5 kilograms. Is it important? Yes. In the worst cases, it can lead to retinal detachment and blindness. What causes it? The blood vessels of the retina originate from a central point where the optic nerve and the optic artery reach the eye, and the vessels grow out progressively across the retina from this point. The growth in an ordered way during fetal life. The growth is the most rapid from 28 weeks gestation to term. When an infant is born prematurely, this abnormal development of the vessels is interrupted, and this is what can lead to the development of ROP. What is the mechanism? This is a very complicated question beyond what we have time for today, but we can think of it as happening in two phases. Phase 1 is after preterm birth in the first weeks of life. Remember, in utero, normal vessel development in the eye occurs at low oxygen tensions. But after birth, there's an increased oxygen saturations, plus we often give additional oxygen therapy. And the effect of the eye is to cause the normal development of the blood vessels in the retina to stop. We see arrested development. Later, in the second phase, there is growth of the orbit in the retina, but the periphery now lacks vessels and so suffers from hypoxia, plus minus lack of nutrients. Therefore, signals are sent out throughout the retina and new blood vessels start to grow, a process known as neovascularization, literally new vessel formation. But these vessels are abnormal, they're fragile, they're weak, they can bleed, and they can cause scarring. It is these abnormal vessels that give rise to ROP. How can we diagnose it? ROP can only be diagnosed by an ophthalmological examination by an ophthalmologist experienced in the diagnosis and treatment of the condition. Therefore, screening of all at-risk infants is needed. These are infants, as I've said, born less than 32 weeks or 1.5 kilograms. When should they be screened? Remember, this is a condition that develops progressively. It doesn't become evident before 4 weeks after birth at the earliest, and usually continues to develop, reaching its maximal stage between 36 weeks and 42 weeks corrected gestational age. Sometimes this is after babies have gone home, and follow-up needs to be thought about at the time of discharge. Pediatric ophthalmologists have a standardized way of describing the retinal changes. These include dividing the retina into zones and clock hours to describe where the disease is occurring, and then also giving any disease a stage that describes the degree of abnormality of the vessels. Initially, the division between the vascularized central retina and the avascularized periphery is seen as a line between the normal vascularized central portion and the avascular periphery. This later becomes elevated, a so-called ridge on the retina, and later the new vessels grow up and onto the ridge, and it is the appearance of these vessels that is used by the ophthalmologist to tell us whether there is ROP in each eye and what stage and zone. The threshold for an infant requiring treatment will depend on the stage of the disease, the location of the disease, and whether it is progressing. Treatment is needed whenever an infant is at risk of retinal detachment and blindness. Most infants with low-grade ROP will show spontaneous improvement over time, with repeated screening every 2 to 3 weeks. But in the few infants with severe ROP, these will require specialist services for surgery or sometimes intravitreal injections of Avistan, anti-vascular endothelial growth factor. This can modify the disease progression. VEGF, vascular endothelial growth factor, plays a significant role in both phases of ROP. In phase 1 ROP, the hyperoxia suppresses VEGF and stops vessels development, while in the second phase, VEGR expression is increased in the retina, which leads to the neovascularization with the abnormal vessels causing ROP. Because treatment of severe disease is difficult, prevention is vital. How can we prevent ROP? It was already known more than 60 years ago that high inspired concentrations of oxygen in preterm infants can cause blindness. So we need to avoid high inspired oxygen concentrations in these babies. But what saturation should we aim at in infants less than 32 weeks gestation? There has been many studies looking at this over the past 20 years. One of the largest, the Canadian oxygen trial, which Dr. Aggie was involved in. These studies showed us two things. First, if we target lower oxygen saturations, less than 90%, we will reduce the incidence of ROP. But, and this is a big but, more babies died in the group where oxygen saturations were targeted below 90%. Therefore, today we are targeting saturations over 90, between 90 and 95% is most appropriate, but also avoiding saturations 97% and above. What else can be done? We come back again to antenatal corticosteroids. The answer is they probably do reduce the risk of ROP by reducing the severity of RDS and making the baby less likely to be hypoxic and require oxygen therapy. The use of caffeine reduces the risk of severe ROP, probably by reducing time needed on respiratory support and the number of apneic episodes and intermittent hyperoxemia. This was shown in the CAP study, again, where Dr. Golan was greatly involved. Attention to nutrition and growth is probably also important, and I will return to this in our last complication, which I'm coming to now. The lung. Bronchopulmonary dysplasia, a chronic disease of the lung where the most important risk factor is preterm birth. Babies are not born with BPD. It develops after birth in some infants due to two main mechanisms. The first is lung injury. What factors are involved in causing this injury? Well, in infants that need mechanical ventilation, they can need or be given high inspiratory pressures. These pressures are forced down the immature, fragile airways, creating shearing forces, and this is known as barotrauma. In addition, and even more importantly, over-distending the lungs with high tidal volumes causes a straining force on the elastin and collagen fibers in the alveolar epithelial layer, and this is known as volume trauma. These mechanisms of mechanical trauma on the immature lung set off inflammatory reactions. What you are doing in your hospitals is excellent because you are using nasal CPAP with the baby breathing on his or her own, which is non-invasive technique. There is no barotrauma, it is lung protective. However, when we use the bag and mask on a preterm infant, we should take care of the forces we are creating. Even though volume trauma and overextension is usually the result of the inspiratory pressure, we should also try to avoid over-distending the lungs of an infant, even on CPAP. A second cause of lung injury after mechanical trauma is related to oxygen toxicity. An infant with significant respiratory disease is most likely needing oxygen. But if the infant is exposed to high inspired oxygen fractions, oxygen-free radicals will be produced, and these are harmful. Exposure to hyperoxia in the critical saccular phase of lung development causes acute lung injury, secondary to inflammation. Acute activation of macrophages, release of pro-inflammatory cytokines, accumulations of neutrophils. This results in the disruption of the alveolar capillary barrier, vascular leak, influx of inflammatory medias, and pulmonary edema. Finally, these infants are also at risk of early onset or late onset respiratory infections that again contribute to ongoing lung injury. These mechanisms of lung injury provoke an inflammatory response, which is supposed to enable healing and repair of the alveolar and airways. But what happens during the development of BPD is these repair processes are continuing, but at the same time, so does the lung injury. The premature lung is exposed to ongoing oxidative and cellular damage, and it is this that leads to a disordered repair where we start to see the changes, such as in fibrosis, smooth muscle hypertrophy, alveolar capillary hyperplasia. If this continues, we will see an infant with an X-ray something like this, old BPD. It's a heterogeneous lung disease, not all the same. There are patches of atelectasis alongside areas of hyperinflation, areas of fibrosis and epithelial lesions, and areas of more normal looking lung. There will be a large decrease in the number of alveoli in this lung compared to a normal lung. Okay, we finished the lung injury for a second, and we move to a second mechanism. Delay, which we see in the most preterm infants, those born before 28 weeks gestation. In these extremely preterm infants, born at the late canicular, early saccular stage of lung development, these infants will suffer developmental arrest or delay in the continuing development of the respiratory system due to ongoing illnesses, respiratory, neck, patent ductus arteriosus, poor nutrition. All these can contribute, and these infants end up with a smaller number of larger alveoli than a normal infant. So we can say that the normal alveolization, which is happening from 32 weeks gestation and onwards, is interrupted. These infants end up with an X-ray more like this. It's a homogeneous lung disease where we see greyish lungs, similar appearance of both lung fields. This is a feature of fewer but larger alveoli and reduced number of alveolar capillaries. It all leads to leading to a less potential for gas exchange. Of course, our worst babies today have a combination of both these two pictures. How do we diagnose BPD? There are several definitions, but the most common for infants born before 32 weeks gestation is if they're still requiring oxygen or positive pressure at 36 weeks gestation. Infants born after 32 weeks, we need to use a continuous 20-day oxygen requirement definition. What is the outcome for infants with BPD? The good news is that the lungs continue to grow and develop for several years after birth. And most infants with BPD who survive will show gradual improvement with time. However, they're at risk of repeat hospitalizations for respiratory illness in the first 2 years of life. They have a higher incidence of reactive airways disease, and they will always have some decrease in lung function that persists into adult life. Now we come to the final look at prevention strategies, this time for BPD. First, let's consider antenatal corticosteroids. Anyone who has followed what we've said about IVH, NEC, ROP prevention would surely expect that antenatal corticosteroids must prevent BPD. The answer is you're probably right, it should do, but it doesn't according to meta-analysis. The most likely reason for this is because antenatal corticosteroids reduce mortality, and so more babies survive who are at the highest risk of BPD. Anyway, I'm not going to get hung up on this as it's obviously a good thing to give. Secondly, the use of non-invasive ventilation, such as you use CPAP. This will reduce BPD, and this is especially the case where it is combined with the use of surfactant therapy. I understand you don't have access to surfactant therapy at present, but with the administration of surfactant becoming increasingly non-invasive, given by small catheters to spontaneously breathing infants on CPAP and not requiring ventilators, plus the development of a new generation of synthetic surfactants, I hope this will reduce the cost and increase the availability of this truly remarkable therapy. My final two options for practical things that can reduce the risk of, again, the use of caffeine. Once again, the benefit was shown in the CAT trial, and this is cheap and effective and easy to use. And finally, returning to something I said I would return to from retinopathy or prematurity, the importance of growth and nutrition. This is a massive subject on its own, but close attention to weight gain and growth must be made throughout the hospital admission, asking ourselves, is growth adequate? Is the baby getting enough protein and calories? I would only suggest that it is a regular, at least once weekly, part of the assessment of each infant, with some local guidelines developed as what to do if the infant is not thriving as needed. With that, I want to say thank you so much for your attention. I realise we've covered an awful lot of ground in a very short space of time, and some of you will be more familiar with these complications than others. I hope I was able to give at least something useful for each person, for each of you. And I'd like to open it up for the option for questions, specifically about the prevention of the complications, if people have comments or questions.
Thank you, Justin. Can you stop sharing the screen, please, so we can see? Okay, so first of all, thank you for extraordinary talk on these important issues. Any questions at this point? Until you're thinking on your questions, I just wanted to re-emphasize that as we are now introducing a CPAP as a mode of helping babies survive and helping preterm babies to survive, we have to know that there are complications of prematurity which can be prevented with low-cost interventions. And Dr. Justin emphasized the antenatal corticosteroids, the temperature control, and the treatment with caffeine, and the appropriate use of oxygen. These are things that we can do on a daily basis in each of our preterm babies to prevent the complications. None of the things that Dr. Justin suggested are high-tech interventions. When you will discuss this in your units, make sure that you think about this future possible complications if we keep the babies alive.
Aggie, when I came to do the talk, I wasn't even completely clear what the antenatal protocol is there, whether they're able to give antenatal corticosteroids or how often they are, because some of the babies I know are not born at the centres.
Ashura or Rita?
Yeah, majority are given DEXA if they are if the woman will deliver or they are suspecting the woman will deliver prematurely. Usually they give twice, they give 2 doses before, 12 hours apart.
Okay.
Yeah. I think we do have data. Benil can maybe for the next meeting a little bit have a general idea what percentage, maybe Dana, you have from your study. We do have an idea, at least what is documented in the files that we receive, how often this is given to the preterm babies in the units. It's a big challenge, as Justin said, because if babies are born very fast, you need at least 2 days in order to complete the course of antenatal steroids. And if they are born in far away hospitals where the awareness is not there, then the steroids might not be given. So it is something simple, but it's not easy to make sure that we have in Beersheba 60%, in Sweden they have 100% or 95% of preterm babies are born after given steroids. And I'm sure that the challenge in your setup is even more frustrating. Questions? Comments? Elon, Mickey?
Great, now you can hear me. Justin, thank you very much for, I think it was very clear and you managed to go through all the complications of prematurity, really kind of, it was flying over it. And I think it was very clear. And I hope that, I know that some of the things are not always relevant, but most of them are, because we know very well, though nobody's, mostly nobody is checking the eyes of babies in special care units. The babies are affected by oxygen and their eyes are affected, and they do have respiratory problems later on. So it's things that it should be taken care of. And when Agi is showing babies on CPAP that have 99 saturation for several days, if it's a premature baby, it's something that you should look at and be aware that babies don't need to be on 99 saturation. 95 is more than enough. They shouldn't be on 80, of course, but they shouldn't be on 99. So it's a point that if there's one point I would take from your presentation is keep the babies on normal saturation. Don't try to get them on the higher range of the saturation.
Okay, and then this Dr. Buedu again. I think it's a very good presentation and eye opener to some of us. For me, again, some few things are clear. For instance, the cord clamping that the last presenter talked about is something we know, but for us over here, it's not a national policy. And so you move to most labor wards and they really, or we really don't give the 60, 90 minutes before clamping cord for normal babies. Then again, the issue of the steroids, I think it's something, maybe after this presentation, I'll personally find the article he made reference to and then look at, because it's something we do routinely. Like Ashura was saying, once we anticipate that a certain pregnancy would be terminated prematurely, then the obvious and the right thing in our thinking that we do is to give some steroid. In fact, these days we can even repeat it. Supposing you have a 28 threatened pregnancy which would want to be terminated early, we give it within 12 hours. But if the pregnancy stays longer, sometimes we are even mandated to repeat it. So with the risk we have spoken about here, I think we have to delve into it, maybe do some studies on our own and then help in influencing policies in our part of the world. So once again, thank you so much. And I think I've enjoyed joining the lecture today. Thank you.
Thank you for your comments. And again, we are very happy that our partners from the OBG side are with us, and we will have more talks about the importance of working together for improvement of the care of the preterm and term babies. So thank you so much for being with us. Again, I encourage, first of all, we can look at the numbers of how much antenatal corticosteroids are given in our preterm babies from the 2 units, and then implement some kind of quality improvement project in your unit and see if you can increase either the antenatal corticosteroids or the temperature control issues. It's all projects that can be done. Temperature on admission is extraordinarily important in prevention of the IVH. Very simple thing to do to keep the babies warm. And we can have numbers. Maybe Benil, we will send you out some numbers that we have on the babies admitted in the last year, and see the nurses can implement some nice quality improvement project and work on these big important challenges. So Miki, you have anything to add to us?
You just mentioned the issue of temperature, and I wonder if in the delivery room, the cradle where the baby is transferred to from the mother at birth, if it has got a warmer above, because that is very simple to install. Really isn't expensive at all. You know, just put a infrared radiant warmer above the area, and this could prevent hypothermia in babies. A very simple measure, and as we see, it is important to prevent intraventricular hemorrhage and other complications. Also, respiratory problems are more severe as the baby is hypothermic. So that maybe it should be looked into.
Okay, thank you. I can tell you that regarding the temperature on admission, about 3 years ago, maybe more, all our babies in Soroka were born and brought to the NICU, and they all had hypothermia. And when we introduced a protocol about how to care for these infants in the delivery room, as Professor Karpus said, heat them properly, dress them properly, dry them properly, all this very simple intervention can cause the possibility to maintain the correct temperature. And today, 99% of our babies are admitted with normal temperature, and the intraventricular hemorrhage decreased in incidence. So it's a very easy and simple and important thing to do. And again, I want to emphasize how important it is we start to keep alive smaller and more younger babies, preterm babies, and we have to make sure that we do no harm and we prevent serious complications. So I encourage again to continue. Yes, Ashura, I saw your hand.
Yeah. So
yes, Ashura.
I wanted to talk about something and then to find the recommendation. So currently at Sontreso, when we are going to receive preterm babies, we put them in the plastic bag to the armpit. But then some people have the concern of the infection. What is the recommendation? Is it a good thing? We have realized when we do that, we get them with a normal temperature when we reach at the MBU. So do you recommend us we should continue with what we are doing, putting them in a plastic bag, or we should stop?
Okay, Elon?
Well, the question is, where is the plastic bag coming from? If it's a clean plastic bag, it should be okay. And it's better to sterilize them. But the other question is, how small are the babies that you use it for? Because again, the very small babies that need to be on, that it's impossible to treat them without invasive ventilation, they will die somehow. Eventually, they will die. So, if you can get clean plastic bags, there shouldn't be any problem of infection. But what Miki, Professor Karpus just said, that to use the overhead heater is very important when you take care of the babies. It's extremely important, and once you will have it, half of the work will be done. The other problem is the transport to the unit, which is not very far from each other, but it is important to be able to keep the babies warm during this transport. And we will have a discussion on transport later on.
Okay, so the problem is during transportation. With the warmer, we use warmers at MBU. That one is fine, but coming to MBU. Yeah,
The nylon bags are suggested in small preterm infants and have been shown to keep temperature better, but and it's no problem of infection.
Okay.
Okay, so